morning, everyone. I hope everyone is doing good. Today we are going to deal with, we are going to deal again with some of the common neonatal problems. But by this time, we are going to talk about the problems which are related to the physiological factors. Yes, the continued process which we had started in the previous session, we'll be talking about the remaining causes. There are certain physiological factors that may result in the neonatal disorders, or we can say the neonatal problems. First one comes the hyperbilirubinemia, hypoglycemia, hypocalcemia. Then comes the hypothermia. Let's now talk about the first one, that is the hyperbilirubinemia. Let me introduce you to this condition. Hyperbilirubinemia, or you can call it as the icterus neonatrum. It is observed during the first week of the life, that is the first week after the birth. In approximately, it is seen 60% in the term, as well as it is seen 80% in case of the preterm infants. The definition of this condition is the condition, it actually refers to an accumulation of the unconjugated bilirubin in the blood that results in the yellowish discoloration of the skin, as well as the yellowish discoloration of the mucous membrane. When the indirect bilirubin it is more than 5 mg per deciliter, it may manifest as the jaundice. As I mentioned the name bilirubin, right? So you may be thinking that what this bilirubin is actually, and what is the role of this which is leading to this kind of condition. Well, this bilirubin, it's a yellowish pigment that is made naturally. That means during the normal breakdown of the RBCs, that is the red blood cells. It usually is excreted through the body in the form of urinobilinogen, that is excretion through the urine, as well as it is excreted through the stool, that is called as the ceticobilinogen. Let's talk about this jaundice now. As this jaundice, you might have heard so many times, or you might have a scene or the faces of the people, or the faces of the children you meet. So this visible manifestation, that is the yellow coloration which you see, discoloration of the face, or you can see the eyes, right? So this is actually the main manifestation of the hyperbilirubinemia. This jaundice occurs when the liver cannot excrete sufficient bilirubin from the plasma, that is from the blood, when the liver is not able to excrete it normally. This jaundice or hyperbilirubinemia, we can say that it is classified in many ways. So the jaundice is of following types: physiological jaundice, pathological jaundice, breast milk jaundice, breastfeeding jaundice. We'll talk about the first one, that is the physiological jaundice, or you can call it as the icterus neonatrum. As I told, this is most commonly seen in the preterm babies, right? So this condition, that's the jaundice, is seen about 60% of the term babies, as well as it's seen 70 to 80% in the preterm babies. In case of the term babies, the maximum intensity of this jaundice is seen on the 4th day of the life, and it will subside by the 7th day itself. Wherein, in case of the preterm babies, this maximum intensity is seen on the 5th to 6th week of the life, and it will subside by the 14th day of the life. What can be the causes for this jaundice? That is the jaundice which is seen in the first week of the life. If the load of the bilirubin is increased over the liver cells, there can be the increased destruction of the erythrocytes, that is due to their shorter, the lifespan, that is they have the lifespan of only 90 days. When there is increased enterohepatic circulation of the bilirubin, that is in the children's intestine, there is a presence of enzyme called the beta glucuronidase, which converts the conjugated bilirubin into the unconjugated form, and then it is reabsorbed by the intestinal mucosa and is transported to the liver. So when this process, which is called as the enterohepatic circulation, when this gets increased, so there is chances of getting the bilirubin level very high, and it leads to the formation of the yellowish pigmentation. The next cause can be the defective hepatic uptake of bilirubin from the plasma. If there is a decreased bilirubin excretion as by the feeding of the baby, which stimulates the peristalsis and produces the rapid passage of the meconium, thus reducing the amount of absorption of the conjugated bilirubin in the stool. Next comes the decreased bilirubin excretion, which can be the another cause for this condition known as the hypobilirubinemia. As while feeding the child, the peristalsis occurs and produces a rapid passage of meconium, thus reducing the amount of absorption of the conjugated bilirubin by stool. Now we'll talk about the next type of this condition, that is the jaundice in breastfeeding infants. When the breastfeeding is inadequate, it definitely will result in the decreased caloric and the fluid intake of the breastfed infants, the baby not receiving enough milk from the mother as to reduce the levels of the bilirubin. As the mothers of the milk, it helps to reduce the bilirubin levels in shorter days. It will begin by the age of 2 to 4 days, and it may take at least 2 to 3 weeks to end up or to subside. Let's talk about the third condition, that's the third type of the jaundice, that is the breast milk jaundice. This is called as the late onset jaundice, as it may begin at the age of 5 to 7 days. Peak bilirubin, it is seen in this condition during the second week, and it then gradually gets decreased. It is caused by the factors which are present in the breast milk, for example, the pregnenolone, the fatty acids, as well as the beta-glucuronidase, which is present in the breast milk, that can either inhibit the conjugation or it will help in decrease excretion of the bilirubin level. Now, the next condition we're going to talk about is the pathological jaundice, and this condition is seen very common in the newborns. This jaundice occurs within 24 hours of the birth, and it is called as the pathological jaundice. Clinical jaundice persists beyond 10 days in the term infants and beyond 14 days in case of the preterm babies. Hemolysis, which occurs due to ABO or we can say the RH incompatibility, as well as in the presence of intrauterine infections, which are considered as the major etiological factors responsible for causing the jaundice within 24 hours of the birth. Let's see some of the characteristics, or we can see the characteristic features of pathological jaundice. As the clinical jaundice, it appears within the 24 hours of the life, as there will be increase in the total bilirubin by more than 5 mg per deciliter per 24 hours. Total bilirubin may increase up to the 15 mg per deciliter or more than that. Direct bilirubin will be more than 2 mg per deciliter. Let's see some of the causes of pathological jaundice. It may occur due to some of the reasons. If there is excessive red cell hemolysis that leads to the increased bilirubin production, if there is a presence of hemolytic diseases in the newborn, when there is deficiency of the red cell enzymes that are causing the hemolytic anemia G6PD deficiency, in presence of the neonatal sepsis may lead to this condition. If the conjugation is decreased or the decrease in the clearance. Crigler-Najjar syndrome is one of the syndrome which is seen in the newborn, that is the congenital deficiency of the hepatic glucuronidase transferase enzyme, and it may lead to the pathological conditions. As in case of the preterm babies, there will be immaturity seen in all kind of the systems. So if there is the impaired liver function seen in these kind of infants, definitely this pathological jaundice will be seen. In case of some of the metabolical disorders, which may be the galactosemia, or it can be the hypothyroidism, which are the etiological causes for this condition. If we talk about some of the congenital obstructions or atresia of the biliary canal, or if there is a viral hepatitis presence, then it may have an impact over the pathological jaundice. How to manage this pathological jaundice now? First of all, it depends on the cause. So the factors which are actually responsible for the condition will be treated first. The blood transfusion or the exchange blood transfusion is required in case of the severe cases of this jaundice. Let's say in general what can be the clinical features or the clinical manifestations of the jaundice. First thing comes in the mind, that is the yellow discoloration of the skin, the sclera, as well as you can see the yellowish discoloration over the nails. Obviously, the baby, the infant will be lethargic or irritable. Child will be refusing to the feed even though you are, taking the child to the breast. The child will deny it. The urine and the stool color will be very dark. How can we diagnose this condition, that is jaundice? First thing is to go for the clinical estimation of the jaundice. In newborns, this jaundice is detected by the skin blanching with digital pressure. The infants who have this dermal icterus drastic to the face only, they'll be having the bilirubin of 5 mg per deciliter. And if the area above umbilicus is involved, then the level of bilirubin will be 10 mg per deciliter. And if the discoloration is seen up till mid thighs, then definitely the level of this bilirubin will be 12 mg per deciliter. And if it is seen till the legs, then it will be more than 15 mg per deciliter. Second thing we can see as the serum bilirubin estimation. If the serum bilirubin level is 5 or more than 5 mg per deciliter, then it can indicate the presence of jaundice. Then comes the non-invasive methods. Engram icterometer, which will help in showing the level of jaundice. Transcutaneous bilirubinometer, which is dealing with the measurement of the jaundice. Again, it is a non-invasive procedure which is guiding us towards the jaundice. Now we have reached to the management of the jaundice. Let's see the pharmacological management which is possibly prescribed or given for the infants with this condition. The first thing under pharmacological condition is the phenobarbital, which promotes the hepatic glucuronil transferase synthesis, which increases the bilirubin conjugation. And it may also increase, or it may also promote the synthesis of the albumin, which increases the hepatic uptake of the bilirubin for conjugation. The second thing comes the metalloporphyrins, especially the tin protoporphyrins and the mesoporphyrin, which will inhibit the heme oxygenase activity, thus reducing the breakdown of the heme to the biliverdin. Then the third thing comes, that is the exchange blood transfusion. Bilirubin can be removed from the blood most rapidly by the exchange of the blood. This exchange transfusion is usually done when the serum bilirubin is more than 20 mg per deciliter. This transfusion is also to be done when there is a serious complication seen of this hypobilirubinemia, and it is rarely seen in the physiological jaundice cases. Then the last part which comes under this management is the phototherapy. Yes, you heard it right, as you are already known to this condition, phototherapy, that is usually given to the infants with the jaundice. In this phototherapy, there is a use of some lights, that is the fluorescent lights, which are usually used for the conversion of the unconjugated bilirubin into the conjugated bilirubin. Now we'll see some of the complications of this condition, jaundice. Hypobilirubinemia. If it's not treated on time, or if it's not treated well, then it may result in the unconjugated bilirubin, which is penetrating to the brain, leading to the neurological dysfunction, which manifests as transient encephalopathy. That is, it's a neurological dysfunction which is seen in early stage, and it is just for a short period of time, and it is reversible. Next complication can be the kernicterus, and this includes the bilirubin toxicity, which leads to the staining and necrosis of the neurons which are present in the basal ganglia and the cerebellum. Let's talk about the another condition which comes under this physiological factor is the hypoglycemia. Hypoglycemia is the most common metabolic problems which is seen in the neonates. In children, the blood glucose level seen as less than 40 mg per deciliter represents the hypoglycemia. What causes this hypoglycemia in children? Presence of the persistent hyperinsulinemia, when there is the limited glycogen stores, which is usually seen in the prematurity or intrauterine growth retardation. There will be the increased glucose use. In case of the hypothermia, glucose will be used in a higher level, so it may lead to the reduction in the glucose level. When there is again the decreased glycogenolysis or there is decreased gluconeogenesis, that's actually the process which leads to the conversion of the glucose or which is helping to store the glucose for the next use. So when these processes are decreased, it may lead to the decrease in the glucose level. There are certain risk factors which are leading to the condition hypoglycemia. The infants with following risk factors, they are at high risk of developing hypoglycemia. For example, the blood infection, that is the sepsis. In case of the endocrine disorders such as the low thyroid hormones, intrauterine growth retardation can be the risk factor. Premature babies, especially, who are always at the risk of getting all the conditions. The clinical features of hypoglycemia can be usually the children or the infants with the hypoglycemia are asymptomatic, but in case of the severe hypoglycemia, the symptoms may be the cyanosis, that is the bluish discoloration seen, especially over the nails, which is seen around the lips, or whole body can be bluish due to this condition. The infant will be having the breathing problems as the oxygen supply is reduced or the oxygen concentration in the body is low. The baby will be presenting hypotonia, that is the decreased muscle tone. The grunting can be seen in the infants as they'll be having a hunger of air. Restlessness can be seen. Twitching and tremors also can be seen. The presence of seizures. Let's see the management for the hypoglycemia. First of all, this hypoglycemia can be treated by initiating the breastfeeding within 2 hours of the birth. The infants with some of the symptoms can be given a bolus of 2 to 4 ml of the 10% dextrose and then followed by the infusion of 5 to 10 mg per kg per minute till blood glucose rises above 40 mg per deciliter. If the hypoglycemia continues even after giving the bolus, then the baby may need some of the medications, like for example, the dioxazide that will increase the blood sugar level, or you can go for the octreotide that will reduce the insulin production. Some of the possible complications of hypoglycemia can be prolonged hypoglycemia can lead to the brain damage or it will affect the normal mental function. There will be the developmental delay in the infants. The seizures can occur if the hypoglycemia is not treated. Then the third condition under the physiological factors which are leading to the neonatal disorders is the hypocalcemia. Can see that approximately 1 of every 4,000 newborns are hypocalcemic. Let's define this hypocalcemia. Hypocalcemia is defined as when the total serum calcium concentration of less than 8.5 mg per deciliter seen in the children. As there will be the decrease in the level of calcium, so you must know what this calcium is actually. As the calcium is the most abundant mineral which is found in the body, the various factors like parathormone or the vitamin D or etc., which will regulate the homeostasis of the calcium and will maintain the serum calcium levels in a normal range. Let's come to the etiology of hypocalcemia. First thing may be seen as the vitamin D deficiency, which may occur due to malabsorption, presence of the malnutrition, when there is the prolonged phenytoin therapy going on, congenital rickets. These may lead to the vitamin deficiency. The next cause can be the metabolic causes. For example, the hypoparathyroidism, hypomagnesemia. Then the third cause can be when there is increased calcium loss from the body, which may be due to the hypercalciuria when there is a excess loss of calcium through urine, or it can be due to the presence of prolonged corticosteroid therapy. Other causes may be like metabolic alkalosis, hypoproteinemia, infants of diabetic mothers. Then there can be the possibility of the infants who are fed with the cow's milk. And yes, the prematurity is the basic cause for getting these conditions. Let's see some of the clinical features of this condition. Early signs can be seen within the 48 to 72 hours of the birth. The high-pitched cry will be seen in the baby. Intermittent cyanosis will be found. edema of the infants. Usually, the abdominal distension can be seen. The periods of apnea are also the features which can lead to the condition of hypocalcemia. The late signs that can occur in 3 to 7 days after or even as late as 6 weeks of the age. They may include the irritability or the jitteriness, muscular twitching can be seen, tremors, then the carpopedal spasm, that is the spasm of the muscles of the hands and the feet. How do we diagnose this condition? First of all, the history of mother is very important as the infants born to the diabetic mothers have the chances of getting hypocalcemia. The blood investigation may include the serum calcium, the serum phosphate. Next, we can see the hormonal assay, for example, the parathyroid hormone estimation. The management of our hypocalcemia condition in infants can be the calcium therapy. It's the mainstay of the treatment for hypoglycemia. The 10% calcium gluconate is administered in dose of 2 ml per kg intravenously to the infants. Magnesium administration is very necessary to correct any hypomagnesemia because hypocalcemia does not respond until the magnesium levels are up to the mark. The fourth physiological condition which comes as the hypothermia. Yes, we'll talk about the neonatal hypothermia, that is defined as the abnormal thermal state in which the newborn's body temperature will drop below the 36.5 degrees Celsius. If the reduction of the body temperature levels are very decreased or progressively getting decreased, then some of the adverse clinical features ranging from the mild to death. The causes of the hypothermia, it may be when there is a lack of attention by the healthcare providers at the time of birth. A newborn is more likely to get this condition hypothermia because of the large surface area per unit of the body weight. A low birth weight baby has a decreased thermal insulation due to the presence of low subcutaneous fat. The clinical features we'll be seeing of this hypothermia. The first thing we can see is the acrocyanosis. That is the cyanosis which is found over the hands, the feet as well as around the lips. The baby's extremities will be cool. The baby you'll find as lethargic. Bradycardia will be present. The feeding will be poor. Presence of hypoglycemia again. Tachypnea can be seen to urge for the oxygen. Obviously, the weight loss is the prominent figure. How to manage the hypothermia? First of all, the hypothermic baby or the infants has to be rewarmed as quickly as possible. It can be done through the skin to skin contact, the presence of the warm room or the warm bed where the baby is to be placed. The baby can be kept under the incubator or the warmer. The baby's temperature, that's the axillary temperature, has to be taken every half an hourly till it reaches to the 36.5 degrees Celsius, and then it can be checked 1 hourly or 2 hourly. How to manage the infants with the moderate hypothermia, that is the range of the temperature between 32 to 36 degrees Celsius. Again, the skin to skin contact is very important, or the child can be kept in a room which is warm or the bed which is already being pre-warmed. In case of the severe hypothermia, that is when the temperature is below the 32 degrees, air heated incubators can be used or the manual ones also. Once the baby's temperature reaches to the 34 degrees Celsius, then the rewarming process can be slowed down alternatively. 10% dextrose can be started intravenously at the rate of 60 to 80 ml per kg per body weight. Administer vitamin K 1 mg to the term and 0.5 mg to the preterm. An oxygen supply is just to be provided according to the level of the oxygen saturation. How can we prevent this condition? First of all, the delivery is to be conducted in a room which is pre-warmed, or it should be in a good patent for the baby. After the birth of the baby, immediately cleanse the baby with the towel, that is soft towel, and wrap the baby in double folded towel. Then rooming in is encouraged, that is the baby is kept near the mother's side. Kangaroo mother care is very important, where the mother is keeping the naked baby with the chest of herself. The bathing after delivery, that's immediately after the birth, it should be avoided to reduce the chances of hypothermia. During the initial postnatal days, the baby's temperature is to be checked regularly. Let me conclude the topic which we have discussed today, that is the problems related to the physiological factors. For example, we have talked about the hyperbilirubinemia, that is, the normally we say it as a jaundice. It occurs when there is a level of bilirubin which is more 5 mg, or it can be the more than 5 mg per deciliter. And we have talked about some of the different types of the jaundice, which can be the breast milk jaundice, which can be the breastfed infants jaundice, or it can be the presence of the pathological or physiological jaundice. And later we have seen some of the more conditions, that is the hypocalcemia. We have talked about the hypothermia, as well as we have talked about the hypoglycemia. So all these conditions which are related to the physiological, or which are usually related to the physiology of the infants, and if there is any interruption with these physiological factors, may lead to some of the neonatal disorders. I'll see you in the next session. Till then, have a good day.